Hi, and welcome to the Vet Dental Show. I'm Brett Beckman, board certified veterinary dentist, and we do this podcast every Wednesday for you, the technicians and veterinarians in general practice, to give you insights and actionable steps that make your dentistry service even better. If you have not already, the International Veterinary Dentistry Institute is sponsoring a live seminar, online training, July 17th, and you're invited. Register at ivdi.org/July, and we'll see you there. So let's go to cases that have cysts. So we're going to talk about that now. And very common to see these, although you may not have seen them, probably because you're not looking for them and taking radiographs on every indication that there are, every indication that there is to take radiographs for finding these. So let me start off by saying, if you have a brachycephalic breed with a missing O5 or first premolar, upper or lower, and specifically lower would be the more common situation. Upper is super less common, but lower O5s in a brachycephalic breed, first premolar in the mandible, if that's not there, there's a really good possibility that there is a cyst forming or that will form. If this is a patient less than 18 months old, 2 years, you're taking radiographs, if there's no cyst that's forming yet, probably not going to be if you don't see it radiographically, but I would still follow it up in another year to make sure. But if it's an older patient, you don't see anything. If it's unerupted, it's not going to happen. But if it's less than that age, if you're there anyway, get it out because there's a good chance that that's going to progress. The crown is under the tooth, where the tooth's supposed to be, which is in the oral cavity. It's in the bone. There's an epithelial root sheath around that tooth that produces fluid. That fluid expands, and by 3, 4, 5, 6 years of age, you get tremendous bone destruction from the cyst. So you want to make sure that if you get these early, when the patient's less than 18 months old, go ahead and extract them, get them out of there before they have a chance to produce the changes that we see. And we see those changes that are really bad. So how do you prevent a fracture of the mandible during and after the procedure when you have a radiograph where the tooth is compromised or the bone's compromised significantly around that tooth root? And Allison Marie asked that question. And so when you've got that situation where you've got a really significant decrease in bone, which would happen if you had a tooth that was partially erupted that had a cyst in it. And if you're watching on YouTube or you're watching live here in the workshop, that is the radiograph that I've just described, where you've got significant bone destruction and there's very little bone left there. If you are doing this and you've got a lot of experience doing extractions of mandibular canine teeth that have that type of involvement where the cyst has been associated with significant bone involvement, the canine tooth's involved with it, then it shouldn't be an issue because you know how to do that without compromising the mandible. If you don't know how to do that, if you've not had experience with a lot of surgical extractions, know the anatomy, have the experience, then that significant bone loss is not something that you want to do. But from that statement, that question, Allison, may be how do we prevent it? We're really careful when we put our torque pressure on that tooth root to remove it where we can't remove additional bone, where it's not feasible to remove additional bone because we may be compromising bone too far apically, and we don't want to do that in some instances. So we're just really careful We don't put a lot of torque on those. We make sure that we're slow and deliberate with our technique, and same approach to root tips. Slow, deliberate, sustained extraction force with a luxator elevator allows us to have really good control over that, and really good control over not fracturing that mandible. So great question. And when we're dealing with something like that, where you've got significant bone, you may or may not be dealing with extraction of a normal tooth, normal canine tooth and associated with a cyst, but a canine tooth associated with a cyst that's not erupted all the way, then that tooth root is really far back in the mandible. Then that presents a situation that involves more bone just from the socket of the tooth, but it's still the same, right, as a real significant cyst that extends back to the second, third premolar or so, which happens when the patient gets older if these are left undetected. Again, back to that first premolar in the mandible that's missing, that you detect radiographically on especially brachycephalic breeds. And I don't want to specifically limit it to brachycephalic breeds because it happens with breeds of any breed or mixed breeds, but specifically them because they're at really high predisposition to that. So recovering following something like that is not a major problem. It's just like extracting those teeth and having a proper flap surgically that closes the area. These are, in brachycephalic dogs, more prone to dehiscence. Why? Because you have a huge tissue mass adjacent to the extraction site that's more, in these cases, again, if there's a huge bone defect that has to be filled, and in our case we use a jugular sample to fill that defect, jugular blood sample. You can use a bone graft and blood, but we just use a blood sample, just as effective. But if you close that long incision that allows you to get into and get all that cyst material out and extract the teeth that you need to extract, then that's a bigger flap, and you're doing it in a brachycephalic dog. And guess what? Especially in boxers, you got that huge boat paddle of a tissue mass or tongue that's laying up against that extraction site, and it's moving back and forth over that extraction site, and it's heavy, and it's placing downward pressure on it. So that makes it more likely to dehiss, and I have had a couple of those over the years in boxers that have dehissed. And if we have dehiscence, generally it doesn't pay to redo those. We let them heal by second intention, which is not ideal. It takes longer. It may be uncomfortable for them for longer, and it does require antibiotics for a short period of time, usually a week, and then that fills with granulation tissue, and it's actually imperceptible versus what it looked like, what it would look like if the sutures were there. It's just not ideal, obviously, with primary intention healing if that suture pattern stays and there's no disruption by dehiscence. So the recovery for that, if it doesn't dehiss, which is a very rare occurrence, a very uncommon occurrence, is like it would be for a mandibular canine extraction. There's really no difference. Elizabethan collar, analgesics for 3 to 5 days. We use NSAIDs. We might use a pain patch, depending on the extent, fentanyl patch, and so whatever your analgesics of choice are, multimodal would be the way to go with that. So great question. So let's go to the next question here. Are there any other situations other than dentigerous cysts, where you would put a jugular sample into a defect or create a clot for improved healing. Amelia Jane asked that question. Amelia Jane, that is dependent upon the volume and also where it is. So if you do an extraction in the mandible, especially mandibular canine tooth, there may not be enough blood in that thick cortical bone when you're ready to close to be able to close. Sometimes you want to go back and you want to scrape that cortical bone, see if you can get a blood clot that's going to come up to the level of the marginal bone that's left. If that's not the case, then indeed, in answering your question, you could use a jugular sample and just fill that alveolus with blood and then suture over the top of it. So really nice question there. Morgan, most common breed, Morgan DeShell. Most common breed for dentigerous cysts is brachycephalic dogs in general. Boston Terriers, pugs are super bad. Boxers are bad, but any brachycephalic dog is up for grabs when it comes to missing first premolar in the mandible. Carol Kluka, how painful are dentigerous cysts? Would a small cyst be painful on palpation such that it might be detected on physical exam? Generally, no. They're not painful. They become painful when they break through the bone and they get into the tissue and form a fistula. Then you have bacteria coming in, inflammation coming in to the defect, to the cyst, causing inflammation and infection, then it's painful. So these go undetected many times, and it would be nice if they were painful and the patient showed signs when they first started, but that's just not the case. It doesn't happen that way. Melinda has a question. I've touched on this a little bit. Are these cyst repairs really suitable for general practitioners? If they're beyond a volume that's manageable with a simple flap exposure and they don't involve the canine teeth, the answer is yes, you can do that. It's like extracting an unerupted tooth. If you're comfortable extracting an unerupted tooth, especially that same tooth, that first premolar in the mandible, which is generally the case if it's early and there's minimal bone involvement, even if the canine tooth has a shadow of involvement that's not too big, and too big would be maybe the same diameter, maybe a little more than the tooth itself that's unerupted, then many of you would be comfortable doing that. Otherwise, be best to refer if you're not comfortable with that. Kyle Johnson asked a question: if not properly dealt with, can those come back? And in other words, is if the cyst material is not removed completely, can those recur? And indeed they can, and indeed they may. I have never had one, knock on wood, that has recurred. We have had one case in a cat where they had a cyst that also had neoplasia associated with it. We just did a case when we were in Orlando or Atlanta, I can't remember, that we just got the pathology back, and it was suspect of possibly having a neoplastic component. That is one of the rule outs going forward, but it wasn't definitive, so we'll monitor that case radiographically in order to determine that. So there could be possibilities where they don't work, and certainly depends on the skill and experience of the person doing the cyst removal, but those are, in our experience, almost non-existent, where you have to look back and see that there is indeed a cyst forming again. Again, the only time we've had that is with neoplastic component to it in a cat that I can recall. But that being said, you do want to follow these up radiographically. We look at them we'll look at that one with the neoplasia in 6 months. We generally look at a year, 18 months in the future to see if there's bone growth, or if there's evidence that there's not bone growth, where we expect it to be a full replacement of that void with bone when we repeat that radiograph. So thanks, Kyle, for that question. Heather, last question here on cysts. Do you do anything if a canine tooth only erupts halfway? And we had an example of that where you could see the crown of the tooth. There was a cyst associated with the entire periodontal ligament space. You could see an increased periodontal ligament space around the whole tooth, especially at the marginal bone level where the crown was. And so in that case where we have a canine tooth that shows changes, obviously we're going to extract that. But if we don't have that and we have a canine tooth that is partially erupted and we see this patient at 18 months or less and there's no changes, there's probably not going to be any changes. We would follow it up anyway, maybe at 2.5, 3 years of age, just to make sure. But we would not we would not recommend extracting. We would recommend monitoring, because those are nightmares, even in the hands of a specialist in some cases, to get out. We have a vet tome now and have had that for several years. We love that. That's super effective at these cases where we're using a periotome, essentially, if you're familiar with that. That's mechanical, that goes down in the periodontal ligament space and loosens that tooth up. But otherwise, they're very difficult to extract, and we definitely would not recommend that, not as a referral. That's got to be a referral if that tooth is only partially erupted. The other thing, Heather, that we can do if it's partially erupted, but the crown of the tooth is just surrounded by bone and there's no cyst there, we'll open up a surgical flap and we'll remove the bone around the crown. And then we'll suture that flap back to where it's at the new bone level, and we're able to keep that tooth. So that's another option. That's, again, a specialty level thing. We do it if we see it on referral, and I wouldn't recommend it in general practice. I would recommend monitoring that unless the owner wants to be absolutely sure that's not going to develop. You can certainly refer for that procedure, or possibly refer for that procedure if that veterinary dentist does that, and some may or may not. So great questions. So thanks for listening to this episode. We'll see you next week. And if you haven't already, please register for that free live new training July 17th. We're expecting around 600 to 1,000 people to be there live on that date. So don't miss out. IVDI/July will get you into that course, and we'll see you guys next week. Take care.